Welcome to When Digital Goes Down, Ensuring Care Continuity in a Catastrophic Tech Crash, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We would also like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. The Users Group is the nation's premier collaborative focused on acute care at home. The Users Group shares resources and best practices, works together to expand our program's reach, and informs regulatory, reimbursement, and payment policies necessary to build the field and spread this hopeful, person-centered model of care. Please visit our website. Be sure to check out our TA Center for helpful HOB program resources and tools, as well as our recently refreshed Research Center. And also please follow us on Twitter/X. You can view any of our 25 Users Group webinars on our website, find a topic you've been thinking about or working on, and take a look. Next, registration is open for our webinar this year, down to the waiver wire. What's next for HA? The 2024 virtual HA Users Group annual meeting. It is scheduled for October 17th. We're building an exciting program. We're featuring keynote speakers, including Drs. Mona Siddiqui and Anupam Jena. There are 2 tracks for new and established programs, a policy update, HA research presentations, and much more. We are also thrilled to announce a late breaking session. The co-leads of the CMS study on the Acute Hospital Care at Home initiative, Dr. Ashby Wolf and Danielle Adams, will be presenting an overview of the study and discussing its findings. Down to the Waiver Wire is the most comprehensive digital hospital at home conference available, delivering a high-quality, cost-effective, and travel-free experience for busy clinicians. CME is also available. You can visit our website using the link or QR code for more details to register. And as in years past, the HA Users Group annual meeting will be a pre-conference for the in-person American Academy of Home Care Medicine annual meeting on October 18th and 19th. Visit ahcm.org to learn more. And we hope to see you virtually or in person. Finally, a team of researchers at Mount Sinai, they're looking to interview hospital and home caregivers for their input on the caregiver experience and range of equity issues related to hospital and home policy, practice, and research. We need your help to connect with these caregivers. To get involved, simply scan this QR code on this slide or contact info@hausersgroup.org. And it is now my pleasure to introduce our moderator for today's webinar, Dr. Linda Deshary. Dr. Linda Deshary is a member of the Hospital and Home Users Group leadership and a national expert on hospital and home programs. She is the Vice President for Clinical Strategy and Implementation at Medically Home, where every day she helps sites around the country implement virtual hospital programs. Previously, she was at the Mount Sinai Health System for almost 2 decades and was the clinical director of Mount Sinai at Home, its home-based service line. Please take it away, Linda.
Thank you so much. So I'm really excited today to talk about when digital goes down, ensuring care continuity in a catastrophic tech crash. And I am joined today by 3 of our speakers. And I'm going to introduce them now, and then I'll talk a little bit more about our panel. So first we have John Campbell, who currently serves as the Chief Information Officer for Mass General Brigham's Healthcare at Home Division, which includes home hospital, traditional home care, and other home-based services. During his 20 years at MGB, he also served as a CIO for post-acute for MGB. John has led the implementation of numerous clinical, administrative, and innovative technology initiatives to improve quality, patient care, and clinical experience and reduce costs. Second, I'm joined by Trini Trong, who's the Chief Medical Officer of Mount Sinai at Home. Dr. Trong creates vision and implements strategies to operationalize, integrate, and grow the clinical services within Mount Sinai at Home, which includes hospital at home, rehab at home, palliative care at home, and other affiliated services. Dr. Trong is a hospitalist and an associate professor of medicine at the Icahn School of Medicine at Mount Sinai. And third, I have Lindsay Williams, who's the Director of Care at Home at Cedars-Sinai. Dr. Williams brings significant clinical and operational experience to Cedars-Sinai with an overall career focus on investigating, creating, and improving outpatient care for vulnerable persons. Prior to her role at Cedars-Sinai, she led the Worksite Labs clinical expansion to deliver decentralized labs and clinical services as their chief nursing officer. So I'm really excited to talk today about our what happened on July 19th with the Crowdstrike that went down. In hospital at home, we often discuss natural disasters. We talk about what happens when the patient's power goes out because there's a storm or a rolling blackout, or there's a snowstorm or a hurricane. And we talk about how do we get to the patient and how are we going to deliver things, provide the care. But today we're going to talk about something different. We're going to talk about what happens if our technology goes down. We're all so dependent on it. Just imagine like when we have can't get Wi-Fi or cell signal, how annoying that is, right? So today we're going to talk about what happens when technology goes down. And everyone can remember July 19th when the cybersecurity company Crowdstrike distributed, I think it was a faulty update, and it caused this widespread but varying problems among many sectors. We heard about Delta, who couldn't send out their flight attendants to the right places. But we also know in healthcare, EHRs went down and other systems. And today we're going to talk with 3 health systems that were affected differently on that day. And what did they do immediately? And what have they done since? If you want to ask any questions, please put it in the Q&A, and I can go ahead and answer we can bring those up as we go along. Oh, thank you, Gabby. And I forgot to mention our disclosures, which they have none, which we've listed here. Thank you. All right, so I'll start with our first question, and I'm going to ask Trini this question first. When did you first learn about this Crowdstrike outage at Mount Sinai, and what happened at Mount Sinai that day, and how were you notified?
Yeah, so I'm going to take a couple minutes just to go through what happened at Sinai, the health system. What I learned is from the CMIO. A lot of a lot of terms I might not know, but I'm trying to bring it down to where I could understand it. So what I understand, as you said, is that there was Crowdstrike, which is like virus prevention system that Microsoft use that to prevent viruses, and it does frequent updates. So at around maybe 12 a.m. in the morning, that when they deploy that 12:09, I have the exact number of when they deployed, and it depends on your enterprise where you are. For at Sinai Health System, we were affected at around 2 a.m. So it was a faulty connection to the Microsoft server kernel. So we went down at 2 a.m. in the morning. So the team here diagnosed it. And then just to take back a little bit, there are a few different operating systems out there. There's Linux, there are a few other ones, Mac and also Windows. We at Sinai are 90% Windows. So you could see the devastation that we went through. So 90% of all of our operations were down, including all the servers, including all the desktop are essential, from the tier 1, which is critical infrastructure, to patient care related, or to the non-clinical servers or operations were all down as well. So then between 3 and 6 a.m. in the morning, our internal team assessed the damage and trying to figure out what's going on. At around 6 a.m., they did receive a fix from Crowdstrike and Microsoft, but it took too long to fix the issue. So the internal team, they developed their own fix. So they were able to fix that. The infrastructure, the core infrastructure, were fixed around 6 to 9 a.m. or so. And then at around 9 a.m., that's when they start to fix the patient-facing, so tier 2 infrastructure, including Epic, which is what we use. So for us at around 9:30 to 10 o'clock, that's when we are back online with Epic, with just patient-facing infrastructure. Then the team, we all got notification via broadcast email and also internal call of emails as well, right after 6 a.m. They sent out and say that this is the issue. And I think there were a lot of tip sheets of what to do with computers we could use after the core infrastructure will recover between 6 and 9 a.m. Is that, is there anything?
Yes, excellent. And when you said like we were notified, just to clear, like every physician was notified, or was this because you are director of a program, you got a special notification?
Initially it was leadership notification, and then it went out throughout the system.
Okay, great. John, I wanted to see if you could tell us a little bit about what
Sure.
happened at MGB with that day.
Yeah, thanks, Linda. So my story closely follows trends, so thank you. Within Mass General Brigham, we have very robust both emergency management programs, so that's across all disciplines, but also within digital, what we call our major incident process. So I got my first page at 1:30 in the morning. And got called into a major incident. Once we're paged, we have to be online within 5 minutes, and the things unfold from there. Also, emergency management also stood up their HICS process. So our administrator on call for healthcare at home was already engaged. So we started the process then. Similar to Sinai, we started with the manual solution from Crowdstrike, which was like 10 steps, and you had to have the highest level of privileges on every workstation. We were, painfully going workstation by workstation. And similarly, some very smart people in our digital organization came up with our own solution that not only did you not have to do the 10 steps because they're automated, but anybody could do it. They were able to put it on a USB drive and automatically grant the privileges. And all you had to do is plug the USB drive in, and it fixed the machine. So that allowed us to expand. So once that happened, I'm starting to go off script a little bit, but once that happened, we were able to get any warm body. So we literally were paging anybody in who was able to help, and put together teams that included digital and non-digital people. And they were going like swarms of bees through the AMCs in particular. Anyway, our Epic did go down, obviously, at first, as well as the majority of our servers were 90% Microsoft too. One of the blessings for us was that our remote patient monitoring system did not go down. So they were not affected by the outage, and that was a real blessing for us, because at least we felt like we had line of virtual sight into our patients, even if we didn't have access to their EMR and all their medical records. We had Epic up by 10 o'clock the following Saturday evening, and we had our reconciliation done by midnight. So we were able to bring Epic back online by midnight of July 20th. So that's the initial trajectory. I think I'll pause there.
Excellent. Thank you. Now I'll ask Lindsay, and Lindsay is obviously in a different time zone. So it'll be a 3-hour difference in her story. So I'll let you speak to what happened in your program.
Yes, it was an early day. It was a very early morning, basically waking up to the calls, the texts, informally from our team members. We had 2 nurses on that day, as well as the nurse manager and myself. So, driving into work, into the office that morning already, just kind of on the phone, talking to the teams, making sure, we're assessing what's going on, the effect on our patients, and patient safety, of course, being number 1 for us in our program. So we kind of had 2 means, right? We had the informal, right, which is what's our teams just calling and texting each other just to remain on top of what was going on. And then we also had kind of the formal organizational response too at the system level, as John and Trini mentioned. And then we also have what within our division or department was called like an incident command center. Right. So like every director, executive director, they kind of corral all of their leadership at a department and division level, right, to be a lot more specific about what's particularly going on in your department and how things are being affected operationally, just to make sure we, know kind of what's happening in real time, and then can, of course, try to handle it as best as possible. So within that incident command center structure, we were meeting probably every 4 hours that day. In addition to, again, the informal calls and texts, just to say like, they see us at home. How are you all doing? What are your updates here? Within our organization, we live within our greater what's called capacity command center. So everything kind of related to flow capacity. So all of our, functions were affected there because we also have our transfer center, patient placement, all of those functions were affected to try and get our patients in and out of the main medical center. So we were meeting very often as a leadership team within capacity management to make sure, we were staying abreast and on top of what was happening, and addressing the immediate needs. As everyone mentioned too, we are majority Windows. There was a few people who had Macs here and there, and they were kind of like the heralds, please help us within our department. But yes, mostly being Windows. So yes, our EHR, we also use Epic, went down in the early part of the day. Our system that we use for our patient monitoring for CS at Home, Seisha, did not go down. So we were fortunately still able to plan care and still have tasks happen in the home. But of course, we were just doing very closely with our physician and our nurse practitioner and our pharmacist, getting telephone orders, making sure we were keeping, copious track of what was being ordered when. So, we went back to kind of old school pen and paper there when it came down to documentation.
Great. So what I'm hearing is that all three of you, Epic went down for a time. It sounds like Lindsay and John, the in-home tech was fine during all of this. Trini, I don't know if you mentioned, was that an issue for you?
Not an issue. I mean, in the home, we don't have continuous monitoring for all patients. We had the biopharmacist, but is not was not affected.
Was not affected. So the in-home for all three of you was not affected. So I'm curious, like, Lindsay, you started to touch on this, but really, like, okay, so between the 6 and 9 a.m., like, that's when rounds happen. That's
Right.
when normally people put in orders. Like, what did you actually do, and how did you care for patients until you were fully back online that day? I know, Lindsay, you started. I don't know if you want to talk a little bit more. I'll throw it to you first, and then we can go back around.
Yeah, so we do huddle every morning at 9 o'clock. And so by that point, everyone was aware. Basically for us, we got, old school, if you want to call it that, with landline phones, and we were able to have our rounds that way. So, folks use their individual cell phones. We used our landline phones and were able to continue to run rounds that way. We also use landlines to reach each of our patients just to make sure they were safe, that they have any impacts from the shutdown. So a few folks that were using their computers couldn't use them, but overall, of course, they were safe and clinically stable. So we kept using that means and gave our patients our landline phone number so they can continue to reach us. In the times that I think 2 of our patients of the 4 that day needed some kind of in-person, or I should say, video, face-to-face communication, and we did use FaceTime just between our nurses and then our in-home clinicians. We were able to FaceTime, so we were able to have face-to-face visits with our patients as well for those who really, I think someone maybe had a cellulitis, right? So we're doing kind of calf measurements just to make sure we had eyes on what was going on. Make sure we're, measuring pain and seeing all of those things to make sure we're monitoring for signs of infection. Like I said, Seisha was running, so we were able to still plan care and plan those activities. Fortunately, up to this point, we had a list of all of the cell phone numbers for our in-home clinicians, and vice versa. They had all of our phone numbers. So we were just able to keep in touch via text. So we were still coordinating activities. We were down a nurse that day, so that was fun. One of our in-home clinicians, we were down a nurse. And so we just had to allow extra time, right? We usually give an hour. We gave like 90 minutes, maybe 2 hours, just in between visits, just knowing that everything was going slow, right? So we let our in-home clinician leadership team know. So they were aware too, and of the plan, just to allow more time for the visit, allow more time for travel in between, so we were able to kind of go from there. Similar to what John said too, as part of our IT is called EIS for us, Enterprise Information Services. They had roving teams deployed to install the patch, or however that was how it was described to me, a patch to fix all of the computers. And similar to what you said, they were gathering everyone who was in the local area to kind of start sweeping all the hospitals with the priority for patient care areas. So we had 3 computers, and fortunately, one of those 3 went down. So the other 2 they were able to use on a limited basis. So with that incident command center system, was able just to advocate and say, hey, we have 1 computer down, as well as the greater capacity command center. So they roved around and eventually installed that patch. So we were back on our EHR system, I want to say probably by night shift that time. So maybe 6:30. There was, ups and downs with that because it would restart, it would stop. I'm like, just don't touch it, right? Like, just leave it alone until I am told otherwise. So by night shift that night, we were able to, get back online, with some sense of normalcy.
Lindsay, I want to get like very, very concrete with a couple things. How did an
Yeah.
order get placed that day? Was it
Sure.
done then, because it couldn't be done in Epic?
Right.
It was a verbal order? Was it a
Yeah.
handwritten order?
Yep,
And
yep.
I do know a little bit about your system, that you're not using your internal pharmacy. So how did like all of that happen?
Great question. Great question. Yeah. So for our system, yes, we used verbal order / telephone order, and we have a protocol for that. And that's kind of included in our downtime plans as well. If our EHR system is down, that we can use those telephone orders. So that's what we used in lieu of placing orders electronically online. Linda, as you mentioned, and for the group, due to the regulatory challenges in California around programs such as these, we cannot use our full inpatient pharmacy. And we have a network of 3 outpatient pharmacies that we use. So we had to have a lot of redundancy there in terms of getting on the phone with our outpatient pharmacies, as well as redundancy via sending emails with all of the patient information for the orders. And then just using our service coordinator network to call, follow up on ETAs to make sure that medications were ready. So yeah, great question in terms of that. We used our TO process and then followed up with emails. Now just using our phones, right, to just send those emails, as well as phone calls, just to make sure everything was getting processed. And if anything was missing, we would have our pharmacist put in a TO with that pharmacy as well.
Great. John, do you want to say a little bit about what happened to the program specifically?
Sure. So lots of similarities to Lindsay's experience. Another one of the blessings of this outage, the nature of the outage is that the update was applied at a specific time, and it was applied to devices that were up and running and operational at that time. The majority of our users and clinicians and administrators in the home hospital program use laptops. And so at 1:16 in the morning, most laptops are powered down, they're asleep or whatever, and they did not take the update. So only 11% of our devices were actually down, and that was amazing. We are still in the process of developing all of our formal downtime procedures. But the good news is, our pharmacy support comes from our 5 licensed hospitals. We were able to leverage their downtime procedures, and also, the majority of the leadership and the staff that work within our home hospital program came from one of the entities who have very robust downtime procedures. So I think people just really knew what to do. Also, we use Teams chat really heavily as our communication mechanism. And, that was up the whole time. So we had, very open, robust communication channels across the program. Again, lots of similarities. We do have, phone lists documented and all that, and had, people calling and checking on patients, and many of the same things that Lindsay called out. But again, I think a real silver lining for us was that even though Epic was down, the majority of the other devices and systems that we used were up, and that really helped us, do the right things to take care of our patients.
Thank you. Trini, I know you're last, but I want to see if there was some other comments you had about what happened at Sinai, specifically to the hospital at home program.
Sure. So when that happened, we informed all the active physicians and also nurses and supporting team and everyone on our team. So they were all aware of this. So our admission process stopped at that point because we didn't have any data to admit. So that team stopped. The team that's still going on was the scheduled visit for the patients at that time. As you know, we affected for about during the patient. So we start seeing patients from 8 a.m. And then by the time it went on, maybe it went back on like 9:30, 10 o'clock. So we weren't affected for the patient side, seeing patient side that long. Epic was back very quickly. So we had all of our active nurses deployed into the home, the physician who was seeing the patients, all the leadership on group chats. at that time to communicate what's going on. We use Zoom to do video visit when the nurse is in the home. So the nurse is going in the home to do the assessment of the patient, and we go on Zoom line to do the visit as usual. And for in terms of the orders, in terms of interventions done, this is where we went to crowdsourcing. So we went through what was pre-pour, what the physician remember, what the nurses remember, what did the patients remember to really take care of the patients at that point. And luckily, that was only a short amount of time. Our nurses and physician take notes during that time by hand. And then by the time Epic went back on, we went back on to do the retrospective documentation. And by 11, I think we went back to normal operation as if nothing happened on hospital at home. And I was telling Gabby this when she first reached out to me, is that I think the reason why we were able to go through this so easily and smoothly is the nature of the people working in this space, like home-based space. We roll with the punches. We're just so resilient. Then whatever comes, we just address the issues and we figure out a way of how to address it. So, and I think for us, the effect was not, I would say, for not that significant. We had, I think, 4 patients that by the time that it was shut down and to that time, and then during that time, we also have team huddle. So they're affecting only 4 visits of the day, earlier visit of the day. So we're not so much of affected. But for our Sinai health system, I think it took for the Epic was back on at around 1 a.m. or so. At 1 p.m. or so on the same day, like everything Epic was back on completely. And then all the tier 1, like patient-facing infrastructure were back by 8 a.m. the next morning. So everything was back. The tier, like the non-clinical facing tier, that was the one that took some other days, some more time to go through. They had to literally go and update each of every single window, laptop, or computer.
Yeah, that seems to be a theme here that what had to happen. I'm going to ask 2 questions that we got from the audience. So one of the questions is, how did you ensure you had the patient and all the nurses' phone numbers ahead of time? So I know it sounds like in all of this, all 3 instances, you had another system available to you. But what happens if like that was out? What happens if there was also a cell phone out? Like, do you have, like, what are you doing that has that that kind of information available to you? And anyone have any? John looks like he's about to say something. Great. I'll go to John.
Sure, I'm happy to go first. So, we capture the patient phone numbers as part of the, intake process, and that information is loaded both into our RPM system as well as our EMR system. For those of you who aren't Epic clients, Epic has a solution called BCA, which is their downtime solution. And lots of patient reports are spooled to these BCA devices every couple of hours. Interestingly, and the BCAs are supposed to be in this sort of super protected domain, although they're also on Crowdstrike. So our BCA devices were affected initially, but our emergency management HICS team, they were the first priority to get remediated once we got the solution. So BCAs were back up and available pretty quickly. In terms of nursing phone numbers, also we keep, we do maintain lists of all of our clinicians and how to get in touch with them, just as part of our emergency management preparedness.
We keep track of all of the staff phone number on our file, everyone from all the providers, nurses, leaders, supporting staff.
Yeah, same. We had as part of just kind of getting onboarded with our in-home clinicians, that was just one of the tasks that we did. So we just had that, sitting, ready and available. And if someone didn't have it, again, we had our Teams chat, we had our text threads, so we can easily share that information. Say if we didn't know a nurse or if it was a new nurse, we would have called our in-home clinician. They have a dispatch number. And that one we pretty much have memorized. So worst comes to worst, we could have called that number and said, hey, we're trying to reach, nurse X, and we could have gotten their information in that way too. Yeah, and then for the patient information, in addition to the EHR, the information also lived in Seisha, and like John, we have a downtime computer that we could have accessed to at least a basic face sheet to get a phone number.
All right, John, I'm going to ask, what did you learn, and what did you wish you had in place at the time?
Sure. What did we learn? We learned a lot. So, I mean, first of all, I'm going to say, and I think my colleagues would agree that you know, so much of what we experienced and did during the COVID crisis kind of prepared us for this role and what we had to do. In terms of what we learned, I think we learned just how resilient we are, right? So I love the comment Trini made a few minutes ago. I often refer to our field clinicians as MacGyvers. They're MacGyvering together solutions, you know, all day long. And if that's not how you're wired, you know, this is not the right program for you to work in. So and I think the resilience extended, you know, across the whole organization. Literally everybody in the organization, digital, non-digital, clinician, administrators, like it didn't matter who you were that day or what your title was. Like everybody just dropped what they were doing. They dropped their whatever parameters they had, and everybody just jumped in and did whatever they needed to do to take care of our patients. I think we learned, I think we learned how this, and again, this is through my digital lens, you know, the solution that was supposed to keep us the safest ended up causing us the most harm. And, you know, that we really, you know, we need to build support structures around this, right? So we shouldn't just blindly take updates from Crowdstrike and McAfee, and like they should be, again, my CIO hat, like we should load them in a test environment, and we should make sure that, you know, they're not going to bring the entire system down. So, so I think, you know, not to just kind of take things at face value and build appropriate support structures around it. In terms of what we, you know, I think in terms of opportunities, you know, just some of the systems and structures that we had to stand up. So for example, I talked about the, you know, the need to sort of bring in lots of staff and, you know, send them out in, you know, small armies to do stuff. Like we just didn't have infrastructure built to do that. We did it, a lot of it on the fly, and people did really amazing things. I mean, we were standing up, you know, volunteer registration systems and scheduling, and, but it was, you know, it was pretty chaotic. And I think we could have more prepared to address those sorts of needs. You know, I talked about Teams being our primary communication vehicle. So on the one hand, that's a blessing and a tool, but on the other hand, it can also be very chaotic, right? So if you have like people talking on 1,000 Teams channels, that's not really effective. Like, so having a structure built up that's sort of predefined for how we're going to communicate through Teams during events like this, I think would be more effective going forward. This might seem simple, but and this is more about our system more broadly, but a little bit to home hospital as well. But even things like being able to get into off-site locations, you know, so like our home care offices, which we utilized as hubs for clinicians to go to get their devices remediated. Like, how do you get in on the weekend? How do you contact the landlord? Who's got a key? How do you know? How do people get access to the site? So even though some of those things that seem really fundamental, you know, we didn't have really good solutions built ahead of time.
Trini, I wanted to ask, did you like refer to a procedure or a policy that was home hospital specific, or was this kind of like the whole hospital's disaster plan that you were following, you know, for those couple hours you were out?
Yeah, so what happened on hospital at home side, we improvised. But we, just like Lynn said, we do have the leadership meeting I think it was every hour. It was an update every hour of what's going on, especially that morning, that we learned that which terminal was working, which computer, downtime computer. See, we had downtime computer, but then downtime computer also were affected, and they were on first. So we know on which floor we have an active computer to go, and we'll go there during that time. But for our hospital at home and rehab at home perspective, we did not have a process.
Lindsay, did you have a process that was specific to home hospital, or was it also, did this fall under a kind of the whole hospital? Or I guess in your case, you're also under ambulatory care partially because of the
Right.
California regulation.
Yeah, it was a bit of both for us, kind of the general kind of emergency response, as well as a specific capacity management, and then CS at home, specifically because we have this extra system called, SACIA, as well as the in-home providers. So for us, one of the things that we did in preparation for our go live, and we just went live with our program on April 9th, is we made this sort of grid that said basically, if CS Link, which our version of Epic, if CS Link was down, but SACIA was up and like the internet was up, here's what to do. If SACIA went down, if this went down, here's what to do. So we kind of mapped out all of those scenarios. This though was a scenario that we didn't exactly have mapped out, where it's like, it's actually the computer. It's actually not any of the systems. It's just the computer. So we did update that document after this instance to be a little bit more encompassing, but we had actually already had a previous outage in June. There was a system-wide internet outage where no one could do anything because everyone was, no one could access the internet. So again, all the systems were working, but the internet was down. So we kind of already had this muscle ready, because in that instance too, we went back to our landline services. And in that case, we couldn't use anything, right? So we just had to call our patients on the phone, follow up within as this outage was happening, which I think all in all, it took about 3 hours for them to get everything back up. So, we kind of were already kind of familiar with this, so we weren't freaking out as much, because at least we could use some computers again, and some of our systems were still working. But yeah, with that, and then in addition to the landline, we did have the advantage of our primary in-home clinicians who were not necessarily affected, right? So if God forbid we couldn't figure out what was happening, the tablet was down, we could still deploy a nurse to that patient's home, right? And then just call them and say, like, is everything okay? Do an assessment and make sure the patient is safe.
Okay, now we've all learned about what happened. We've all experienced it. What are we going to do differently in the future? Lindsay mentioned one thing. You've updated that table of different systems out. John, also, you mentioned a few things previously. Are there other things that you're going to do going forward because of what you learned? I can go to anyone. John, go ahead, Lindsay.
Sure. So a few things that we have done in the meantime. We have wireless hotspots now, which again, it wasn't necessarily from Crowdstrike. It was from the internet outage that we had the month prior, but now we have that. So we could, send the good thing about our program, right, is that you can kind of do it from anywhere. So if we needed to, we could send our nurses home, right, and with a hotspot, or send them to another location, in the medical center, and have them work with a hotspot. We have also worked with our emergency response director for 2 specific federal services. One is called WPS, or Wireless Priority Service, and the second is called GETS, or Government Emergency Telecom Service. So WPS is a wireless priority service where it's a free program to opt in, and you just provide your cell phone number, your account number, and your cell phone carrier, and they will opt you in automatically to basically a priority wireless network. So if our staff need to reach our patients, they need to reach their loved ones, they have priority calling. So in a situation like this, or another type of emergency, if there's a lot of calls, we can get through. And then the second thing, the GETS program, it's actually a physical calling card. Again, this is a free program too, but you get an actual calling card, and you could use these 2 together, right? So if I'm on a landline, I could just use my calling card, and there's like a series of numbers that you dial. And then if I'm on my cell phone, I could use the calling card as well as WPS to get priority access, so we can continue to reach folks over the phone. So those are some things that we have done in the meantime since this outage, just to make sure if we need to call folks that we can continue to reach them.
I could give a quick update as well. So from the system perspective, the Sinai system, they told me what they're going to do is, what do they call the update or upgrade, the bundle system upgrade that just happened. So they would go T1. So they explained to me what it means is that instead of getting the most current version of whatever software it is, they're going to go a version behind. So make sure everything is tested. Just as John, you say that, in a test environment. So they're going to go through with that. From our side, from hospital at home and our home-based programs, we have the flexibility of having our nurses go into the home, and then also using landline and cell phone as needed. And we follow our hospital's downtime procedures, very robust downtime procedure, as John also said as well, lab, pharmacy, all of that. But specifically for us, we have requested to save a process to save the patient's registration information, including the addresses, the phone number of the patient, and then best contact information, saving all active orders at the end of the day, and saving the last progress note that was done by the physician. We'll save it, but it will go to an email, like our Sinai email. And if in case the system, something like this happen again, then we will be able to access this, unless the email also goes down. For us, the email didn't go down. We were able to use that. So those are some of the things that we're working on.
Who's pulling that information from the record every day to send an email? Or is that an automatic thing?
Automatic process.
Okay.
Yeah, I'm going to say, I think on the operations side, I think this will be a real catalyst to really advance our downtime planning work. I think you all know it. You've been through it. It's not the sexiest work, and it's hard to maybe attract all the attention and the resources to get the work done. So I think it will help accelerate and advance that work. And it'll also give us a real live situation that both inspires us and will help inform how we go about doing that work. Both on the operations side and within digital, there was lots of after action, reporting, and both, again, operations and digital have a set of action items and plans that came out of this event. So, I mentioned some of the digital things have more sort of prepared plans for communication and scheduling and other things. And then on the operations side, again, really just to have those robust procedures for an event where maybe we don't get so lucky, where all our devices are down or our RPM is down. So again, in many ways we got lucky, and this is a bit of a wake-up call to, again, really have those plans if something more catastrophic does happen in the future.
Yeah, I like Lindsay's grid that, because of all the kind of different scenarios that are possible. I'm sure
Yes.
everyone's thinking that in one way or another, but that resonated with me.
Yeah.
I have two questions from the audience right now that I wanted to bring up. One is, what was the catch up after this? There was these manual orders, these phone orders that were going to pharmacies that I heard from Lindsay. I thought, Trini, I heard you say that doctors were writing some things down and then waiting to, enter it in afterwards. So what was that catch up? And who did it? How long did it take? Specifically for the hospital at home parts of your program. I'm sure there was obviously much larger impacts in the whole health system. So, Lindsay, I saw you nodding, so maybe you had something.
Sure. Yeah. I think for our day shift nurses who were the ones that felt the brunt of the change, I think they maybe stayed another hour hour and a half, after their shift ended. The orders were honestly pretty straightforward to put in because our providers were still there. Obviously, everyone understood the scenario, so everyone pitched in just so our providers were happy. Our physician and NPs were happy just to place those orders again, of course, with copious notes saying that this was, delayed on account of the outage. And then what was the catch-up work for at least our team was just writing their notes, right? Just having robust notes of what happened during the visits, that we checked in with them during an emergency, documenting that the patient was safe, vital signs, all of that. That was really what I had urged our team to make sure that they copiously documented, is that the patient was fine during this period. Unfortunately, we didn't have any emergencies or anything that happened kind of that we didn't expect in addition to the outage, but that was really the catch-up work. And so what they just stayed a little bit after their shift just to catch up on documentation, and then we were pretty much caught up.
So what I'm hearing is the individual providers just took notes for the day of what happened, either an order or the notes, and then that person themselves, as soon as things were up, were the ones who
went back and
did stuff.
Put their orders in.
John or Trini, did your health systems do anything different? Was there another upload of data or something separately?
So our experience is very similar to Lindsay's. I mean, first of all, the decision to retroactively order and, what has to be entered, what's the minimum necessary, et cetera, is established centrally through our HIM leadership. But once we had clarity on what needed to happen, similarly, the actual outage was 24 hours or less of Epic. So the catch-up process was not that onerous, like it would be in a multi-day event. So again, very similar to Lindsay's experience.
And for our side, it was even shorter. So we were able to just go back, and by 11 o'clock, everything was back on, and the orders appear back as they were before. Only anything new during the visit that the physician need to enter again.
Another question from our audience is, were the patients or their family caregivers informed during this time of this? And, what determined, you might not have known how long it was going to be. If it was like a 5-minute outage, do you notify? And how do you kind of make those decisions?
Yeah, for us, we, as soon as, having the organization-wide notification obviously was a huge sign. That's like, okay, this is not just us, right? Because computers go down all the time. You restart, you maybe call IT, help support. So in those scenarios, we're not necessarily calling, right? Because that's just an us problem. But once we're hearing from Incident Command Center, once we're getting these emails that confirms that it's a system-wide issue, that's when we go ahead and let our patients know, that we're having an outage. We're not sure of the length, but here's our phone number. We're going to keep checking on you, so that they feel like they're part of the process.
Again, very similar to Lindsay's experience.
Yep. And Trini, it sounds like yours was shorter. You may not have even had time to.
I think for a couple of patients, they were part of the crowdsourcing, but I think we didn't have time to inform patients even. And remember, our nurses go into the home, so that's part of the rounding as well. So it didn't, from the patient's perspective, it didn't really affect them very much.
Yeah. And then there's a question here about the types of communications that were done. Is the group chat secure, HIPAA, secure, which I think someone mentioned Teams, which I know in some organizations they use a HIPAA secure, that's all fine. And then I guess kind of as a corollary to that, was there any system you used that day that maybe you don't use typically, that may not have those same, protections, but you were doing, the best thing clinically for the patient at that moment? I think, John, I mentioned, I heard Teams for you. So that was that your standard communication way?
It is, and our version of Teams is HIPAA secure. So again, we just heavily leverage Teams. I don't think we stood up any new communications mechanisms that day.
Yeah.
We actually rely on our, so we'll chat about logistics, but then for clinical care and what the orders are for whom, and that's through, we use emails for those patients. It's like, this is the patient, these are the orders, these are the things we need to check on today. And then video visit.
Right. So your email was up, so you were able to do that. Okay. And Lindsay, was there any sort of system that had to be done differently that day?
No new systems. Yeah, everything that kind of the Trini and John mentioned, same things we used. Emails for formal things. We have, for our program in particular, we have specific Teams channels just for our program. So we have one specifically around patient care. So when Teams was back up, it had kind of was intermittent, in and out. But we would put some things in there, but then formal order things, the TOs, like we said, we're writing it down and then putting it in the system afterwards.
I'm going to go with one more question. Was there any discussion about if this lasted longer, would you have planned to return patients to the brick and mortar? I heard Lindsay, you were meeting every 4 hours or so. It sounds like Trini, you were like quick, but maybe for John and Lindsay, was there talk, okay, it's now been 8 hours. This is, still not all fixed. Is there a point where we need to do something different for the existing patients at home?
Sure. So, once our emergency management and HICS command structure got stood up, that, the notion of that longer term scenario planning was part of the discussion. So we were both, we were planning for it both at the local level within home hospital, but also again in partnership with our emergency management and our what's called our enterprise asset management. So that's our central patient flow function. So anyway, yes, there was active scenario planning. And if it had gone on, another 12 to 24 hours, we probably would have had to start pulling the trigger on some of those plans. And again, we got lucky that we didn't have to.
Is that discussed at all with you, Lindsay?
We actually did not discuss that, but it's an excellent point. I think for our team, it would have been a matter of, meeting as a full command center and just going with what's safe for the patient, right? If there was, again, fortunately, we didn't have kind of any acute things. Everyone's clinical course was as we expected. And we could still get people into the home, we could still get their vitals, we could still perform care. So in that case, we didn't necessarily consider bringing them back, but if there was a patient who maybe had something the day before, or what we definitely didn't do is enroll any new patients, right? We didn't get anybody new into the program that day, just for the risk of, having anything fall through the cracks. But we did not consider that for our patients, but it is a conversation that we, would have if there was anything indicating that the patient for some reason wouldn't be safe at home. If a caregiver, support changed, or, if someone's like, oh, usually my daughter helps me with meds, but because of the outage, now she has to do something. That's the kind of, we were kind of consider bringing the patient back. We also do have, though, within our network, home health aides, right? So there's a lot of stuff we can still give the patient so they can remain safely in the home.
This was, I think, a super great conversation. I learned a ton about what everyone did during this one incident. And I'm really glad we spent some time talking about this. It was, as I opened in the very beginning, I think we spend a lot of time on natural disasters and the patient's electricity going down, or how we're going to get to the patient if it's a snowstorm. This was also just as important a scenario to plan for. So thank you so much for bringing all these ideas. I'm going to turn it back to Gabby. Please, everyone, don't go away yet. Gabby has a few more announcements, and then we'll close it out.
Hi, all. Thank you all so much for that wonderful panel. Just to close us out, again, our registration is open for our 2024 annual meeting. Again, sessions include the CMS presentation on acute hospital care at home. We have 2 new tracks for programming for new and experienced programs. And we'll have our keynote speakers from healthcare thought leaders, including Drs. Mona Siddiqui and Anupam Jena. There will be lots of presentations, awards, networking, and more. And also, if you bring a group, you will save. at a discounted rate. You can scan this QR code to learn more about the annual meeting and register today. I'll just leave this up here for a minute. And then also, as a reminder, we're looking for caregivers to be involved in our work at Mount Sinai. We are interviewing hospital and home caregivers to learn more about their experience and range of equity challenges relevant to HOB practice, research, and policy. To get involved, please scan this QR code or contact info@howusersgroup.org.
I'm going to interject right here, Gabby, because this is really, I think, really important. This is a topic that a lot of people want to know about, the caregiver experience in hospital at home. The study is interviewing, I think there's looking for about 5 more caregivers to complete the study. So if you have a caregiver who would be willing to talk, you can make a referral for this, and they'll reach out.
And then again, you can check out all of our webinars on our events page at howusersgroup.org. We've done 25 so far. And then for more information, please go to our website, howusersgroup.org. You can check out our Technical Assistance Center, as well as our featured resource on the Emergency Preparedness webinar. And once more, just thank you to the John A. Hartford Foundation and the American Academy of Home Care Medicine as our partners. And thank you to all of our wonderful panelists today, and Linda for moderating.